Hello everyone, this is Yvonne Waneke doing a presentation on cardiomyopathy. The case study that we are looking at is based on a 23-year-old man who was recently evaluated after an episode of syncope that occurred shortly after a funeral for a 21-year-old cousin who had also died suddenly. They presented with transient mild dyspnea on exertion and palpitations. They had no associated chest pain. There was forceful systolic heave and apical pericardial impulse displaced far to the left on the chest wall based on physical examination. Chest X-ray showed cardiomegaly with slight atrial enlargement, and an echocardiogram was done which confirmed the presence of left ventricular hypertrophy. Liver enzymes were slightly elevated, and the serum markers to check for myocardial infarction, the enzymes and the troponin were negative. Here is a breakdown of the genetics of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the most common genetically transmitted cardiac disease with broad morphologic and clinical spectrum. It is mainly an autosomal dominant condition caused by mutations in sarcomeric proteins with a prevalence of around 1 in 500 in the general population. First-degree relatives of known sarcomeric hypertrophic cardiomyopathy patients have 1 in 2 chance of developing this disease. This condition is linked to over 1,500 genetic mutations, most commonly missense mutations in beta-myosin, heavy chain, which is 40%, and myosin-binding protein C-sarcomere, which is also 40%, and a troponin of 11% in genes. Here is a visual example of a normal heart in comparison to our heart with the hypertrophic cardiomyopathy. The most significant thing noticed in this picture is you can definitely tell the left ventricle is definitely enlarged and it's thickened. And that is what we mostly see. It's the most common clinical presentation with the hypertrophic cardiomyopathy. The clinical presentation that is seen in this disease mostly involves the asymmetric basal anteroseptal left ventricular hypertrophy with outflow tract obstruction due to systolic anterior motion of the mitral valve. We also see reduced exercise tolerance, dyspnea, chest pain, which was absent in our patient in this case, pre-syncope and syncope on exertion, which was definitely present in our patient. Heart failure syndrome, atrial arrhythmias, which can lead to stroke, or ventricular arrhythmias leading to syncope or sudden cardiac death. The ages of presentation do vary in this disease. Diagnostic tools and treatment. Most of the tools that are used to diagnose hypertrophic cardiomyopathy are histologically, which is like the fibrosis, the small vessel disease, disarray, and no infiltration. Family history is very important, especially when it comes into the whole genetics aspect of that. Echocardiogram and cardiac imaging, and it can also be used for risk stratification, defining features such as obstruction and subtype, detecting early disease, and also in planning intervention. Genetic testing can definitely facilitate the identification of family members at risk to develop this condition. The results of genetic testing may promote detection of this disease symptoms by identifying those in need of increased surveillance or preventative interventions, such as an implantable cardiac defibrillator. The goal of treatment is to relieve symptoms and prevent sudden cardiac death through medications such as beta blockers, lifestyle changes such as diet, exercise, and surgical procedures.